Yeah, so the manager function was really to help onboard new infection preventionists in the facilities because some facility there is no one else there that's an IP. So to offer support, we did a lot of surveillance. So to try to take that off of the facility IP's plate so that they could be out rounding and seeing what's going on in the hospital instead of sitting at a desk doing surveillance, and then helping facilitate conversations between the local IP leader and the local leadership within the facility. So to help with alignment, in terms of what we're trying to accomplish as a company and also as a division. So just helping with that alignment between the facility IP and their facility leadership. And being a liaison between the two, to come to mutual agreements and understanding. So basically, any support that they needed, we were more boots on the ground, more in the facility, working side by side at the time. But then COVID came and changed a little bit of that. So then my role shifted into filling vacancies. So if there was no IP, I would have to go and spend some time at that facility to make sure, things were in order from an infection prevention perspective. Also, just taking as much away from their plate as possible in terms of any work that could be done remotely. So again, all of their surveillance, whatever day-to-day tasks that could be accomplished, from remotely from a computer, so that they would be free to be out in meetings with their teams, figuring out what we're going to do about COVID, and also being out there rounding and being a resource to the staff. And so shifting into the AVP role, again, this role now looks different than it did, especially during COVID. So if you can imagine during COVID, a lot of it was sitting in meetings, figuring out strategy, looking at numbers, deciding, are we going to be universal masking this week? Are we not going to be universal masking this week? How many staff are sick? How many staff do we have out? What's the number of, COVID patients in the hospital? Do we have enough PPE? So it was very focused on COVID. But just prior to COVID, a lot of it was building infrastructure for the IPs and the hospitals within the division. So we got the division model stood up. COVID happened, so it all kind of shifted into support mode. And now that we're kind of on the tail end of COVID, or it's waning a lot more than it was, there's now an opportunity to revisit that infrastructure piece, that standardization piece, that back to the basics piece. And so my role hasn't been so much as focused on COVID uh, in that regard, but strategy around how do we align all of our facilities around best practice and IP? How do we make sure that the IPs in the facilities have everything they need? How do we make sure that we are doing things to make sure they want to stay in their role? So they feel wanted, they feel valued, retaining IPs longer, and how do we attract IPs to our organization and to our program. And so, spend a lot of time working on those sorts of things in this role now. I still do quite a bit of site visits. So I still am on site quite a bit, even though it's 15 hospitals. I try to get to all of them as much as I can. I'm still very connected to the local IPs there. So I have at least a monthly one-on-one with every single IP leader in our division, if not bi-weekly. And that's not for me to micromanage. That's for me to understand what their needs are and help them in any way that I can. So again, it's kind of a shift back to the same type of thing I was doing at the Department of Health. That consulting, coaching, mentor, and support role is really what this looks like.